Okay, so let's start. We'll be doing neuro in the first session, and yeah, again, I'm already apologizing pre-session apology for any kind of honking, voices, and stuff. But I'll try my best to talk as loud as possible. I mean, narrate the whole thing as loud as possible. So, neuroembryology, we're going to start with. Okay, so nothing else. We're just going to look at this ectoderm overlying the notochord. Ectoderm overlying the notochord, you have the notochord niche and you have the ectoderm on top. That gets converted to neuroectoderm, which basically forms the neural plate, neural fold, neural tube. So plate, fold, tube, PFT. Okay, pulmonary function test, PFT. Okay, and then it forms crest, neural crest. This happens on day 18 and day 21. Okay, so this is the sequence. Next, the one of the questions you'll remember that had come, notochord, nucleus pulposus. Notochord becomes nucleus pulposus, the intervertebral disc in the adults. So notochord, intervertebral disc. Okay, nucleus pulposus. Remember this. All right. Neural plate is the one that is going to give rise to a neural tube as well as neural crest cells. Okay. So neural plate, tube, crest cells. That's what happens. And that side is PFT, plate, fold, tube. Day 18, day 21. Okay. Next, alar plate and basal plate. So alar plate and basal plate. Which one was the alar plate? Which one was the basal plate? That is important. So this is from MKT obviously, since you can see it is in orange. So neural tube, you have dorsally, you have sensory, lateral. There are 4 nucleus over there. That is the alar plate, and this side it's the motor medial 3. Okay, and another very important thing. Okay, what are these? Okay, because TGF beta has come. Alar plate, alar, see, basal is motor, basal is front towards, basal is samne, basal is more front. So basal is going to be ventral, basal is going to be ventral, and this is going to be motor. Okay, so basal, motor, ventral, sonic hedgehog factor. Okay, and this side alar, your alar TGF beta, also bone morphogenetic protein, it is regulated by. All right, uh, this is, I don't know why I wrote this. Anyways, whatever. This part is very important. So alar plate, if you have to remember, okay, it is AD. Okay, AD. BD, although it looks the same, but it is AD. Okay, alar, alar, ADS. Okay, SAD. You can remember SAD. Okay, SAD. Okay, SAD maybe kind of SAD. Okay, TGF beta. I mean, TGF beta is like a cytokine kind of. Okay, and whenever you think of cytokine, is always inflammation. Inflammatory people are always kind of sad. See, I'll be mumbling and I may make some kind of mnemonics also as we go. Okay, so yeah, okay, after this I'll put up proper videos, but now it's like going to be very fast. So TGF beta, alar plate, dorsal, sensory, alar. Okay, so sad, sensory, alar, dorsal, sensory, alar, dorsal, sensory, alar, dorsal, sad. Okay, and this side is just the opposite of this. Okay, BMP, TGF beta, you have to remember little bit. Let's go through this. Okay, so sad, okay, that was dorsal. But the sensory, alar, sensory alar, this thing was dorsal. Okay, sensory alar was dorsal. Okay, so sad. Okay, that is going to basically, when it opens up, it will go lateral. Okay, all these nucleus will go lateral, and these are 4 nuclei. Okay, medially motor, there are 3 nuclei. Okay, so motor mein there are sensory mein there are 4 nuclei, motor mein there are 3 nuclei. You have sulcus limitans in the middle. Okay, and this is going to be sulcus limitans over here. Okay, now when the neural plate opens up, basically, okay, this fold, it opens up kind of. Okay, so you have all the sensory, you have all these efferents, that is motor. Efferent stands for motor, na, that those are the 3 structures. Okay, they are all medially. Okay, because they are what, ventrally placed. Okay, so motor nuclei ventrally placed, so that's why. So you have GSE, SV, and GV. Okay, this again will come across. Okay, just to give you a picture and just to give myself a picture, basically. So GSE, SV, and GV. Okay, next is GVA. Okay, you have all the afferents. Okay, So the afferents would basically be your this thing, this GVA, SVA, GSA, and SSA. Okay, so just to again, general visceral afferent was general sensation. Special visceral afferent is only taste sensation. General, that is this thing. General this is, and SSA. Okay, next is GVE. GVE is gonna be glands. Okay, general visceral efferents. Okay, so glands ka secretion, everything this is gonna do. Okay, so generally visceral efferents, and SV is gonna be branchial muscles and all this arch. Okay, and GSE is going to be your general sensory efferents. That's going to be all the extraocular muscles and stuff. Okay, so all the skeletal muscles is going to be these two, that is GSE and SVE. Okay, special visceral efferent is basically the branchial muscles and so on, stapedius and all of that. Okay, that we'll do it later. That is not really required. Oh no. Okay, this is what I was fearing. I mean, not a, I mean, just let it be. Sometimes it just gets scrolled up too quickly. So, fine, no problem. Where were we? Yeah. Okay, second page. Okay, first page. Now, quickly. First page, we're not going to linger. Then come to the next part. Okay, come to the next part. Okay. Oh god. Okay, this hangs up a lot. Okay, so just give me a moment, and especially when it is like, you know mm, when we just have to, just give me a moment. I think I'll control it using the mouse keys only. Where did the neuro portion go? Yeah, this is it. Okay, see, next is going to be this. Okay, this is the stelencephalon and rhombencephalon and all of this. Okay, so what happens is, this part we finished, TGF beta, all that you remembered. Okay, SAD, remember SAD and TGF beta. SAD because of TGF beta basically. Okay, so let me just adjust this a bit. Okay, so this looks pretty good. Okay, now telencephalon, look at just this diagram. Okay, prosencephalon, prosencephalon, front. Pro means front, brain, telencephalon, diencephalon. So prosencephalon gives rise to telen, dien. Okay, PDT. Okay, telen, dien. Okay, when we in Calcutta, they used to call PDT. Okay, like the ones who used to do super speciality. So PDT kind of. Okay, so teal and dian. Okay, more than that, you just have to remember this middle one. That midbrain is meson. Okay, midbrain is meson. So teal will obviously give the cerebral hemispheres and basal ganglia and everything, and lateral ventricle. That is the cavity. So here this side, okay, is the, what is this? Okay, this is the hemispheres, and this side is the all the CSF ka flow. Okay, then we have diencephalon, that is thalamus, hypothalamus, retina. Okay, important. Retina is very important. Even optic nerve, optic solve, neurohypophysis, all of that. Okay, so basically is going to give rise to thalamus, hypothalamus, retina, optic stalk, optic nerve, neurohypophysis. See, if you can't see it right now, okay, again I'll make videos that will be very slow. Fair, you can see it that time. Now you can just listen to my voice. Okay, thalamus, hypothalamus, retina, optic stalk, optic nerve. Okay, so optic stalk basically is thalamus, hypothalamus, optic stalk. Optic stalk gives rise to retina and optic nerve. Okay, and it forms the neurohypophysis as well. So all of this is coming from the diencephalon, and basal ganglia comes from the telencephalon. Okay, that is like just in contact with the brain, so it's very close. Okay, so first the atrial ventricle, then the third ventricle. Okay, third ventricle comes from the diencephalon. Next, we have mesencephalon. Meson means middle, means mid. Okay, so mid brain and cerebral aqueduct. So there we have cerebral aqueduct. Okay, that is basically a thin portion that is connecting the third ventricle to the fourth ventricle. Okay, so yeah. Okay, so we have lateral, though, two ventricles. Then we have third ventricle. Then we have cerebral aqueduct. Then we have upper part of the fourth ventricle. That is going to be have the hindbrain portion. So hindbrain portion is basically rhombencephalon. Okay, so rhombencephalon, you have hindbrain rhombencephalon. Rhombencephalon is going to give the metencephalon and myencephalon. Okay, so this is kind of what, alphabetical. Okay, ME is same. Okay, ME is same. S comes before T, right? So S, तो इसीलिए meson first, then meten. Okay, meten is from the hindbrain, meten is from the rhombencephalon. Okay, next is we have pons here. Okay, so we've got pons here. We have got pons, and behind the pons we have cerebellum, and then you have upper part of the fourth. Oh God, upper part of the fourth ventricle. Okay. Okay. So upper part of the fourth ventricle. Fine. Next is myencephalon. Okay, myencephalon. Y comes the last in the sequence. So myencephalon, you have medulla, and we have lower part of the fourth ventricle. Okay. Now you can see this is in blue, this is in blue, this is in blue, this is in blue, this is in blue. All of this, where has it come? It has come in NEET PG. Okay, so that is important. And the previous one, okay, the previous one, this one also, TGF beta also had come in NEET PG. And this notochord, nucleus pulposus, intervertebral disc, this also had come, this has come in INI. Okay, this has come in INI anatomy. So remember the color code. Okay, I'm not going to tell for each and every this thing that this has come in NEET PG and this has come in INI. Okay, whenever you see something purple, you're going to look at it and think that yes, this is INI. Okay, whenever you're going to see something blue, you'll look at it and you'll think yes, this is NEET. Okay, so that is it. All right, so yeah, okay, and this blue, when you see this blue, then that means it is some kind of a memory hook. Okay, so meson means middle. Okay, mesenchyme बोलते हैं ना, we say mesenchyme, so meson is middle. Okay, so that is done. एक बार और, once more, just do this quickly. Prosen is Telan and Dian. Okay, Prosen, Telan, Dian, cerebrum, two hemispheres, lateral ventricle, and then what do you have next? Okay, beneath that you have basal ganglia. Okay, next you have meson. Meson is middle. Middle means midbrain. Okay, that is going to be third ventricle. Okay, because iske baad you'll get that cerebral aqueduct. Okay, so okay, I forgot this in between. Fine. Okay, sorry. Okay, I was actually not looking at it. Alright, Prosen was Telan, that we remembered. Okay, but Prosen also gives rise to Dian. Okay, so Dian is all thalamus, hypothalamus, everything related to emotions basically. Okay, emotions, hunger, all the reflex activity. Dian, you can say diencephalon, you can basically say Dian. Okay, basically Dian. You have Dian. Dians are very scary kind of. Okay, so Dians, they look at you with big eyes. Okay, I'm just making mnemonics as we go. ठीक है, Dians, they look at you with big eyes, so that's why it is going to be retina. Okay, and thalamus is like all the reflex stuff, and it doesn't have anything to do with the consciousness part. Okay, so that is going to be thalamus. Okay, and even the hypothalamus, that is related to hunger, and hunger and all the sensations and all that, so that's why Dian is related to hypothalamus, thalamus, and everything related to vision, that is the optic stalk and the optic nerve basically, and even the retina comes from diencephalon only. Okay, and third ventricle. Okay, mid meson, and that is going to be cerebral aqueduct. Okay, mid meson cerebral aqueduct, chota sa, small. Okay, so that is done. Okay, and hindbrain, you have the metencephalon and you have the myencephalon. So metencephalon and the myencephalon. Actually, this can come. Okay, this is very, can come as match the following. Okay, metencephalon, pons cerebellum, and pons cerebellum, upper part of the foot and lower part of the foot ventricle. Okay, so that is important. Now this is very important. Okay, this has come before. Okay, in INI and this thing. So central peripheral nervous system. Okay, neuroepithelia. Okay, this, just remember, obviously CNS neurons, all this is fine. Okay, the glial cells also comes from the epithelia only, and crest cells. Okay, so crest cells, what does it give rise to? So this was one of the mnemonics that Nikita ma'am had written. That's called MPSC goal. Okay, so MPSC goal is basically your melanocytes, parafollicular cells, parafollicular C cells. Okay, that basically comes in medullary carcinoma thyroid, may it increases. Okay, so that's why. Then you have Schwann cells, chromaffin cells, ciliary muscles, corneal endoderm, ganglion, odontoblast, adrenal medulla, leptomeninges, arachnoid, and pia mater, and dura mater. It gives rise to mesoderm. Okay, So this is like basically the whole this thing. So iris muscle also very important. Iris muscle is a part of the neuroectoderm, that is the pupillae, sphincter pupillae and the dilator pupillae. Okay, that is not a part of the mesoderm, so that is very important. Okay, but then which part of the nervous system is supposed to be derived from the mesoderm? That is the microglia. Okay, microglia is basically macrophage like cells, that is going to be the microglia. Okay, next is another important thing, crest, branchial arch mesenchyme is also from the crest. Okay, so branchial arch mesenchyme is also from the crest, and neuroepithelia has everything to do with the CNS, and neural crest cells has everything to do with the PNS. Okay, so yeah, ganglion, when they say, they mean the parasympathetic and sympathetic ganglion. Okay, when they say odontoblast is fine. Okay, adrenal medulla we can understand. Okay, adrenal medulla also. Leptomeninges mainly arachnoid and pia. Okay, because dura is derived from the mesoderm. DM, you have ना DM बोलते हैं ना, डिस्ट्रिक्ट मैजिस्ट्रेट, सो DM. ठीक है, नेक्स्ट MPSC गोल, this thing remember. So MPSC goal, melanocytes, parafollicular C cells, Schwann cells. C is chromaffin cells, ciliary muscle. C stands for three things: chromaffin and ciliary muscle, corneal endothelium. Okay, and that's it, is goal, odontoblast, adrenal medulla, and leptomeninges. Okay, next we come to this. Okay, so this has come before, that acetylcholinesterase increases in this. Okay, see these two dots. Okay, this has come in INICET before. Increased acetylcholinesterase in the amniotic fluid is a this thing confirmatory test for spina bifida occulta. Another very important thing, that banana sign had come in one of the exams. Okay, spina bifida banana sign. Okay, this is in radio. Okay, banana sign. Okay, so that is important. Next, let's quickly go through this. Okay, so that was day 18 to day 21, right? So fourth week of development, not fusing and everything. Okay, important diabetes. Okay, so diabetes also, not only folate deficiency but also diabetes. It can also happen in diabetes. And then what all do you have? You have increased alpha fetoprotein in amniotic fluid. Okay, so increase alpha fetoprotein in amniotic fluid and increase acetylcholinesterase in amniotic fluid is a helpful confirmatory test. Okay, so amniotic fluid में it is alpha fetoprotein, serum में it is increased acetylcholinesterase. Okay, so amniotic fluid, again I'm repeating, amniotic fluid, A for amniotic fluid, A for alpha fetoprotein. Okay, amniotic alpha fetoprotein, serum acetylcholinesterase, this is going to be serum acetylcholinesterase in amniotic fluid, this is also increased. Okay, so these are all amniotic fluid parameters that we see. Okay, that is all the acetylcholine, this thing. Okay, amniotic fluid. Okay, so we see amniotic fluid and in the serum, both में we see AFP. Okay, दोनों में AFP we see, but in case of acetylcholinesterase, that we are only going to see it in the amniotic fluid. So this is very important. Acetylcholinesterase we see it in the amniotic fluid only. Okay, but alpha fetoprotein we see it two places. Okay, and everything will be seen in the amniotic fluid. Amniotic fluid, alpha fetoprotein, acetylcholinesterase, all is AA. Amniotic fluid, alpha fetoprotein, acetylcholinesterase. Okay, increased. Okay, all this is increased. Okay, but this is the exception and this is important. Spina bifida occulta, normal AFP. Okay, in this is going to be normal AFP. That is very important. Normal AFP in case of spinal bifida occulta. That is important. Next, now let's don't see all this thing. Okay, we'll just this thing from here only we try to decipher. Okay, so first thing, okay, these three, all whatever you can see down, it's all caudal neuropore. Okay, caudal means near the bum. Okay, so it is caudal, near the buttocks, it is going to be caudal. Okay, so caudal neuropore, we are going to see it in the lower vertebrae. All right, and obviously in this case what happens, everything is intact. Okay, so there's no hernia. Okay, the dura mater is intact. Okay, and when a normal, this is like normal. Okay, so this is normal. Now see spina bifida occulta, everything is like the normal only. There is no hernia. The only thing is there's a tuft of skin dimpling that is present. Okay, and dura mater is intact. Okay, so and obviously this, now when the dura mater herniates, okay, so occulta mein, see this occulta mein dura mater was intact, there was no herniation, but meningocele occulta is coming out. I mean this dura mater is coming out. Okay, so when it is coming out, okay, the meninges, they start herniating. Okay, so this is the entire meninges hernia, but then the neural tissue still hasn't herniated, then is meningocele. Okay, because meninges ka seal, okay, meninges ka sac, that has come out. Okay, spina bifida occulta means is hidden. Okay, till now it is not herniated. This, okay, is meningocele, it has come out. So it has come out. Okay, so that's it, this also comes out. Next is meningocele. Myelo stands for spinal cord or something like that. So meningocele, it is, even the neural tissue has come out. Now all this was what, all this was caudal neuropore. Okay, caudal neuropore, everything here was caudal neuropore. Next, another this thing, myelomeningocele. Okay, you'll have this thing, cauda equina. This is important bus. Okay, so diagram is done. You just have to see which tissue is herniating. Okay, here no hernia, no, that's it. Okay, and cauda equina, the fact that myelomeningocele, you're going to have cauda equina. Next is myelochichis. Okay, myelochichis, this is also called rachichichis. Okay, uh, just pardon my pronunciation. Okay, so myelochichis, okay, this is going to be rachichichis. Okay, and rachitis, or whatever you want to call it. Okay, exposed unfused neural tube without skin and meningeal covering. Okay, so that is myelochis. Okay, so rachitis is unfused neural tissue without skin or meningeal. Meningeal covering is also not there. There's no skin covering also. Here at least you had some skin covering. Okay, here you don't even have that. Okay, this is the common part for all. You have some defect in skin. Okay, it's not that the skin covering is completely absent. Okay, there's thin or absent, but thin or absent also there. But here you don't have meningeal covering also. Here at least you have meningeal covering. Here you don't even have meningeal covering. Okay, next is anencephaly. Anencephaly is rostral. Okay, those were what, caudal. Anencephaly is rostral. Image very important. Okay, gynae point of view, ultrasound, go and see. Okay, so no forebrain, open calvarium. INICET, they keep asking the ultrasound for anencephaly. Okay, so rostral neuropode, no forebrain, open calvarium. Okay, again, rostral neuropode, samne, front. Front means forebrain. Forebrain, what were the derivatives of forebrain? Okay, forebrain were prosenkephalon. Prosenkephalon was telenkephalon, dienkephalon. Dienkephalon, dien. Okay, so thalamus, hypothalamus, optic stalk. Optic stalk was giving rise to optic nerve and retina. Okay, so no forebrain. Okay, and open calvaria. Okay, and here you have third ventricle. Okay, here you have first ventricle. Okay, when the first you have lateral ventricle, and then you are having, I just revised the previous page. Okay, like this is what you do. Okay, you see forebrain here, you revise. Okay, forebrain, what did you study about forebrain in the previous page? Okay, so open calvarium is done. Okay, here open calvarium. So rostral neuropore, open calvarium, forebrain, clinical findings, polyhydramnios, because nothing to swallow. Okay, can't swallow. So that's why, since they can't swallow, okay, go and watch the respiratory video. In that there's Potter sequence. Okay, Potter sequence mein there's oligohydramnios. Okay, just like that, TEF, okay, tracheostomy of esophageal fistula, that also has polyhydramnios. This is important. Anencephaly has polyhydramnios. Okay, because obviously there's no one to swallow the amniotic fluid. That's normal swallowing is not happening. Okay, next we come to holoprosencephaly, and quickly we get this done with. Okay, so holoprosencephaly means this thing. Okay, prosencephalon hasn't divided. Okay, so obviously your is going to be a single eye and all of that. Okay, so you can just imagine this thing. So developmental field defect, fine. Okay, developmental field defect, and you have two cerebral hemisphere not separated, week 3 to 4. This is important, week 3 to 4. Sonic hedgehog pathway. Okay, sonic hedgehog pathway was what else for basal plate. Okay, what was for allar plate? TGF beta. Okay, so sonic hedgehog pathway, defects, cleft lip, cleft palate, moderate form, and cyclopia in severe form. Because prosencephaly, you don't have this thing. Prosencephaly, your diencephalon was only giving rise to the optic stalk and the retina and everything. So cyclopia. Okay, so moderate form, cleft to cleft palate, Severe form cyclopia, increase of pituitary dysfunction, diabetes insipidus also you can get, because all of this is prosencephalon. Okay, thalamus, this comes from the thalamus hypothalamus. So this particular thing, it comes your posterior pituitary comes directly from the hypothalamus prosencephalon. Okay, maybe seen with patau, maternal alcohol use, patau. Okay, Patau, okay, Patau 13. Just remember there's a mnemonic ki 13 ke ho gaya, so Patau. But then this is actually Patau syndrome. I'm telling you, just go and watch the picturized video. Okay, that is a very good image mnemonic. Okay, on Patau syndrome. Okay, that Patau syndrome, trisomy 13. It has cutis aplasia and this thing, and you have arachnodactyly or something. Okay, so we'll come across that. Okay, so that is Patau syndrome and maternal alcohol use. Okay, so risk factors is done. This has come sonic hedgehog pathway. Okay, so sonic hedgehog pathway causes holoprosencephaly. This is very, very, very important. Okay, next MRI reveals monoventricle, obviously, and fusion of facial ganglia because it did not divide. Okay, next is lesioncephaly. This was important. Okay, this is due to neuronal migration issue. Okay, neuronal migration. Okay, so failure of neuronal migration due to smooth brain. Okay, so that's why resulting in smooth brain lack gyrencephaly. Three things are associated: microcephaly because obviously you don't have this thing, you do not also gyrencephaly to make the brain big, ventriculomegaly, and hydrocephalus. Microcephaly, ventriculomegaly, hydrocephalus. I do not have a mnemonic for this. Okay, just repeat it again: microcephaly, ventriculomegaly, and hydrocephalus. Okay, in case of lesioncephaly. Okay, if you have some mnemonic, then you can post down. Okay, next page we come to Chiari 1, Chiari 2 malformation. So Chiari 2 has come before, Dandy-Walker has also come. Syringomyelia also sometimes they give. Okay, so specifically they had asked this ki Chiari 2 mein you have that means non-communicating hydrocephalus you get where. Okay, so you have this non-communicating hydrocephalus. Okay, so first you have Chiari 1 malformation. In this, one, okay, means only cerebellar tonsils. Okay, one means only single structure. Okay, that is going to cerebral tonsils inferior to the foramen magnum. It is basically coming now. Most importantly, Chiari 1 happens in children. Okay, it happens in adults. Okay, Chiari 1 happens in adults. Asymptomatic headache and cerebellar symptoms and associated with syringomyelia. Okay, so Chiari 1 associated with syringomyelia. For all these four, I'll tell you, picturize. Very good mnemonic ka this thing, very important. Go through it. Okay, so ectopia, you have tonsil, one structure. In Chiari 2, you have two structures. You have vermis tonsil as well as vermis tonsil the cerebellum. So cerebellum is one structure, and the second structure that is herniated is the medulla. Okay, so here you have non-communicating hydrocephalus and aqueductal stenosis, lumbosacral myelomelagoencephalus. Okay, so because you had that sacral myelomelagoencephalus, you have paralysis, sensory loss at loss, below the level. Okay, loss at the level and below the level. Okay, Chiari 2, okay, is more severe, presents early. Okay, Chiari 1 is adults. Okay, Chiari 1 manifests in adults. Okay, and Chiari 2 manifests in children earlier because it's more severe. Obviously, two structures, Chiari 2 structures. That is going to be more severe. That is going to be in the adults. Okay, next, we have Dandy-Walker. Dandy-Walker is agenesis. See, even if I'm, breathing and sounding like a SOB patient, but still, I mean, bear with it. I am going to breathe and this thing. In usual videos, I don't do this, but then now we just have to get this done with. Okay, so that's why. Dandy-Walker. Okay, Dandy-Walker, you have agenesis of cerebral, cystic and fourth ventricle. Okay, cystic enlargement of the fourth ventricle. Okay, now try to remember fourth ventricle was what? Fourth ventricle was all the down portion. Okay, that was cerebral aqueduct was what? Cerebral aqueduct was midbrain. Okay, and in case of this thing, cystic enlargement fourth ventricle was this only. Upper part of the fourth ventricle was cerebellum pons. Okay, I mean mainly cerebellum. Okay, and lower part of fourth ventricle you again had. Okay, so that's how correlate. Okay, that fills the enlarged posterior fossa. So cystic enlargement, fourth ventricle. Okay, see, Chiari 1 malformation, you have it with Syringomyelia. Okay, then here again you have Chiari 1 malformation. Okay, this is herniating down. Okay, and then after that, this is herniating, And here you have Dandy-Walker. Okay, this is cystic enlargement of the fourth ventricle. See this. Okay, so cystic enlargement, non-communicating. This is associated spina bifida. Okay, so spina bifida. Alright, so Chiari 1, syrinx. Okay, Syringomyelia. Chiari 2, okay, Chiari 2 was aqueductal stenosis and all that. Okay, and Chiari and Dandy-Walker syndrome is spina bifida association. Okay, fourth ventricle, now that you have to remember. Next, just go and see the pixarize, you'll remember this. Okay, next is cystic cavity. Your Syringomyelia. Just a second. Okay, so Syringomyelia, we basically have, what do we have? Central canal of the spinal cord, fiber anterior wise spinothalamic tract. So since spinothalamic tract is obviously, you'll have a cape like this, very important, cape like bilateral symmetrical also. Obviously spinothalamic tract is anterior wide commissure spinothalamic tract is mainly for pain and temperature. Okay, so upper extremities, because it is at the cervical level. Okay, so bilateral cape like this thing, this like this you can eliminate. Okay, fine touch sensation will have to be preserved, because fine touch, this thing, it is more of those other structures. Okay, so this thing is done. Chiari one malformation related to this other thing, your scoliosis and trauma and tumors. Okay, so just a second. Okay, most common mainly cervical, thoracic, lumbar, come from top to bottom. Okay, so cervical, thoracic and lumbar. Okay, and cape like deformity is important, and which tract, that is the spinothalamic tract. Okay, so here obviously you have the syrinx. Okay, and you have lateral spinothalamic tract. So the syrinx is like in the middle. Okay, it's in the cord, right in the middle. Okay, so that's why this anterior commissure is getting compressed. So this lateral spinothalamic tract that is crossing over from this anterior wide commissure, it is compressed by the syrinx. So that's why there's a loss and pain of temperature, cape like this thing. From C5 to T4, it is this thing. Okay, so here you can see the syrinx. Okay, so done na? Cystic cavity within the spinal cord. Okay, central canal of the spinal cord. Cystic cavity within the central canal of the spinal cord. Next, the trunca development. Okay, so trunca development, you basically have what? Okay, you have first. Okay, now this is very important. This is very important for INI, and we have to go like really slow with these. Okay, so yeah, first we go with the sensations and everything. So, see, anterior two-third of the tongue. Okay, so anterior two-third of the tongue is going to be from the first pharyngeal. Okay, anterior two-third, first pharyngeal arch. Okay, first pharyngeal arch, mandibular nerve. Okay, so sensation is mandibular. Obviously, trigeminal is all about sensation. Taste is your this thing. Taste is a facial nerve. Okay, so taste is facial. Okay, taste is facial. Your seventh nerve is face. Okay, seventh nerve is facial. Taste is facial. Okay, and it's going to be V3, first pharyngeal arch, third to fourth pharyngeal arch. Third to fourth pharyngeal arch, posterior one third of the tongue. That is going to be the ninth nerve. Okay, sensation and taste both. Okay, that is going to be ninth nerve. Extreme posterior, you're going to have cranial nerve 10. Okay, so that is important. I'm going to pause the sound a bit. Okay, because someone is backing up their car and it's making quite a lot of noise. I hate this noise. Okay, so quickly we'll just do this. Okay, so V3 sensation. So just remember arch 1 is first arch is anterior tooth of the tongue. Okay, that is supplied. The sensation is supplied by the V3, that is mandibular nerve. Okay, and then the taste is supplied by what? Facial nerve. Okay, so that is important. Facial nerve supplies the taste. Then you have sulcus terminal, valid papilla. Okay, from the valid papilla, then you have sulcus terminalis. In between, you have the foramen cecum, and then you have posterior one third of the posterior one third is third and fourth arch, third arch. Okay, so it is mainly taste as well as sensation is from the glossopharyngeal nerve. Okay, and extreme posterior is all the cranial nerve 10. Okay, so that is done. Next you have the motor innervation. Okay, so motor innervation, this is very important. Okay, so here this is this also I'm like this thinking after a very hate this much. I mean, oh, okay, let's continue. Okay, so for all the muscles of the tongue, they are supplied by palatoglossus. Okay, so all the muscles of the tongue, they are supplied by the palatoglossus except one. Okay, that is all the muscles. What have I write? Oh, all the muscles are supplied by cranial of 12. Okay, that is hypoglossal. All I wrote this is like wrongly annotated. Okay, it is cranial nerve 12. Okay, so all the muscles they are supplied by cranial nerve 12. All the muscles of the tongue they are supplied by cranial nerve 12, except one muscle. Okay, that is palatoglossus. So palatoglossus is supplied by cranial nerve 10. How will you remember? That is palatenglossus. Okay, so palatenglossus is a nice mnemonic. Okay, so that is done. So motor innervation is via 10 to palatoglossus. Okay, so palatoglossus. So basically, it takes the glossus towards the palate. Okay, so you can say that it elevates the posterior tongue. Okay, so palatoglossus, per for palate. Okay, per for posterior tongue, glossus, and it is upwards during swallowing. Okay, so that is a very important this thing, and everything else is supplied by the 12th nerve. Okay, so everything else is supplied by the 12th nerve. Okay, now another one very important this thing. Yeah, this picture is extremely important. Okay, I don't know. Oh, I think I must have taken this picture from one of the MERS or something. Okay, so this is dorsum of the tongue, and this is styloglossus coming from the styloid process. Okay, this is hyoglossus coming from the hyoid bone. Okay, green. This is genioglossus. Okay, genioglossus, it spans most of the tongue. Okay, and hyoglossus is the depressing action of the tongue. Obviously, it will pull the tongue down. Obviously, towards this thing. Okay, genioglossus is safety muscle. Okay, and the protruser prevents the tongue from falling back. Okay, so genioglossus, this is the genioglossus. It prevents the tongue from falling back. Okay, and remember there are two genioglossus. When one side becomes paralyzed, okay, so what was we have to find out that when wait first finish this geniohyoid. Okay, geniohyoid is niche. Okay, now genioglossus is going to be safety muscle of the tongue. Okay, so basically what happens, okay, in this case, when you have the tongue like this, you have one genioglossus from this side pushing it and protruding it in this direction, means outward direction. Okay, and then you have another genioglossus. uh, oh god, wait, uh, okay, okay, so see, when you have one this thing, you have one genioglossus and the other genioglossus. So basically what happens, genioglossus has to protrude the tongue, that is push the tongue outside, no? So when this side genioglossus, suppose it got paralyzed, okay, so it'll this side will it'll just turn towards this side or something like that, like this side will not be able to push it, so it is just going to be pushed by one side, something like that. Okay, so that we need to review it. Okay, so yeah, I think that is more than enough. And yeah, so That's why it's ipsilateral. Yeah, exactly. So cranial nerve 12 palsy. Okay, when you have cranial nerve 12 palsy, basically it's supposed to be ipsilateral. Okay, so you're supposed to lick the ipsilateral side. Okay, that is the licking motion. Okay, you're supposed to lick the ipsilateral side. Okay, so you're going to lick the ipsilateral side. That's what I was trying to say. Okay, that genioglossus basically is the safety muscle of larynx, prevents the safety muscle of the tongue. Okay, prevents the tongue from falling back, and that's why it, you know, this cranial nerve 12 palsy, tongue ipsilateral, lick your wound. Okay, so basically lick your wound. It the paralysis happens on the ipsilateral side. So when you have ipsilateral, like the ipsilateral genioglossus, when it stops working, okay, that means the ipsilateral 12th nerve has stopped working, okay, and that side becomes weak and it's not able to protrude the tongue. So that is important. Okay. Okay, so we finished the embryology part, and more or less. Okay, now quickly we'll do the anatomy and physiology and get into the pathology, because pathology is way more important. Okay, so neurology. Okay, the here neuron markers you have to remember, that is neurofilament protein and synaptophysin. Okay, neurofilament protein and synaptophysin is the neuron marker. What is the marker for astrocytes? See, these markers will be important when, okay, when we'll be doing this thing, bone cancer, I mean your neuro cancers. Okay, so synaptophysin, neurofilament protein. Synaptophysin has come a lot of times, I mean you keep listening to synaptophysin. Next is most common type of glial cells in CNS, okay, is astrocytes. Okay, again, where was astrocytes? Astrocytes is development from neuroderm, but microglia was mesoderm. Okay, because it's phagocytic. Okay, so this was neuroectoderm. Okay, your astrocyte, everything was neuroectoderm except for this. Okay, that is microglia. So astrocytes, reactive gliosis in response to, undergoes reactive gliosis in response to neural injury. Glycogen is one of its fuel, and GFAP is its marker, and neuroectoderm it is derived from. Okay, it is resistant to focal cerebral ischemia, Next is microglia. Is uh, Microglia is phagocytes, right? So obviously it will be from the resident monocyte lineage. Okay, this has come in NEET. Okay, as usual you can see blue. Okay, so that will be NEET. Okay, important, nitric oxide and this thing. Okay, what are the inflammatory mediators that is released? Nitric oxide, glutamate. Okay, nitric oxide, glutamate, not readily discernible by nissels. Okay, so most important is mesoderm. And here's something about HIV. Whenever HIV comes, you have to read. Okay, so HIV infected myoglia fuse to form HIV infected microglia, they fuse to form multinuclear giants and CNS, that is seen in HIV associated dementia. Okay, and this forms rod cells in case of neurocephalus. Okay, and they, in case of neurocephalus, they are microglial nodules. Okay, so HIV infected microglia, they form multinuclear giant cells in case of HIV associated dementia, and in case of neurocephalus, it forms this rod cells. Okay, or microglia nodules. Okay, it is called neuronophagia. Okay, means what it does, neuronophagia. So that is that. Next is ependymal cells, ciliated columnar, very important. Ependymal cell, where does it's all, it's related to CSF, so ciliated simple columnar, okay, and then you have microvilli. Ciliated simple, what, lining ventricle, central cortex, all that, central canal of spinal cord also. Okay, central canal of spinal cord also, remember this. Okay, you can miss it out. Obviously, neuroectoderm, specialized endodermal cells, ependymal cells in the choroid plexus. Okay, and apicus are covered by cilia and also microvilli. Something like, microvilli भी है, cilia भी है, दोनों, both it has microvilli as well as cilia, both it has. Okay, next we'll come to myelin. Okay, so myelin. Okay, myelin has high concentrations of sodium. Okay, and CNS may have oligodendrocytes. PNS, okay, PNS myelination is done by Schwann cells. Okay, CNS may oligodendrocytes. This is going to, and here it is Schwann cells. Okay, you don't need to learn this up much. Okay, another exception. Okay, Cranial nerve 2. Cranial nerve 2 is coming from where? It is coming from diencephalon. ठीक है, optic stalk retina, optic nerve. So that is going to be oligodendrocytes. Okay, it is although a nerve, but these. But then cranial nerve 3 to 12, those are all PNS system. So it is going to be Schwann cell. Take okay. Next, okay. This protein is actually this thing that neuron has this protein. Okay, sodium V. This some channel or something it was. Okay, 1.6. This is actually from Showman sir. I had seen some video. Okay, so it's from there. Okay, 1.7. If it gains, then primary. If there is gain of function of this sodium 1.7, okay, of this pain this thing, then there's primary erythromelalgia and paroxysmal pain disease or something. Okay, so that is not very this important. Okay, another this thing is this electron microscopic image, so we understood. Okay, decreases the membrane capacitance, this thoda sa. Okay, increases the membrane resistance, decreases the capacitance. Okay, increases phase length constant, decreases time constant. Okay, whether we understand don't understand, just read that up thoda sa. Okay, basically it increases resistance, obviously it increases resistance, so it's going to decrease the capacitance. Okay, and length is constant, is increasing, so that's a time constant, obviously decreasing things will be this thing. Next is Schwann cells promotes axonal region develops from neuropressor. Neuropressor was MPSC goal. Okay, MPSC goal. Injured in Guillain-Barré. This is important. S100 is a marker that has come. S100 is a marker that always come. Basically, in Guillain-Barré, they were like which cell is injured and this thing in case of need. Okay, so Guillain-Barré is the Schwann cell. That is the what is the marker? S100. S100 Schwann. Take care. 100 1 WANN, just pronounce it 1. So S1. Okay, this is like a random mnemonic. S1. Okay, 1 becomes 1. Okay, and S100. Okay, so S100. All right, next is oligodendrocytes. Okay, this is important. Okay, all these like which are the this thing. Okay, which are the means it is injured in which of the diseases, so that is important. Okay, that part is important basically. Okay, so oligodendrocytes, you firstly have node of Ranvier. This is all this is fine. Okay, just remember this much, obviously all this is okay. They myelinate as many as more than approximately 30, that is it. Okay, predominantly rather all that is not required. Neuroectoderm, that we understood. Okay, Schwann cells also neuroectoderm only. MPSC goal, MPSC goal का S stands for this, O stands for oligodendrocytes. Okay, MPSC goal. Fried egg appearance, very important. Oligodendroma and all that, you get it in fried egg appearance. Fried egg appearance. Okay, so fried egg appearance, it comes from here only. Fried egg appearance. S100 was what? S100 was Schwann cells. Okay, and multiple sclerosis, progressive multiple leukoencephalopathy. Multiple sclerosis, progressive multiple leukoencephalopathy. So now one thing, we had MS and we had GB. Okay, so remember this. Okay, MS is oligodendrocytes. This is mainly related to central nervous system, and that's it. GB was what? GB was Schwann, and that was PNS. Okay, so this is a marker of difference. Okay, so MS is oligodendrocyte, and Guillain-Barré is Schwann cell. Okay, Guillain-Barré Schwann. Okay, and oligodendrocyte is going to be MS. Okay, or progressive leuko and leukodystrophies. Okay, so this is like a point of contention, and it will help you with the pathology later on. Okay, next, okay, what have I written over here? This I think, yeah, this was something to do with Showman Manna sir's this thing. So local potential. Okay, local potential happens in the body, and dendrites may you get EPSP and IPSP. Adult neuron centrioles, microtubules. Adult neuron, they have centrioles and microtubules. Okay, so basically isoelectric galvanometer, and RNP is maintained by leaky potassium channels. That basically potassium goes out, and that's why you have negative inside the cell. Voltage gated sodium channel. Where is it maximum? Where is it minimum? So voltage gated sodium channel is maximum in the node of Ranvier, okay, where there is 2000 to 12,000 per micrometer in initial segment. So initial segment needs to be, and nodes of Ranvier you need to conduct, so that's why maximum voltage gated sodium channel. While minimum you'll get it in myelin and axon knob. Okay, so myelin and axon knob. Okay, next is neurogenesis. Neurogenesis, hippocampus, dentate gyrus. Okay, so okay, neurogenesis, where all you can have neurogenesis means neurons usually do not undergo regeneration, but you can have neurogenesis in hippocampus, dentate gyrus, olfactory bulb, and subventricular area of the lateral ventricle. Okay, subventricular area of the lateral ventricle. Okay, so hippocampus is a long-term memory. Okay, so horse. Okay, basically host. So hippocampus, olfactory nerve, and subventricular area of the lateral ventricle, and this thing, and those two, 2000, 1000, all that we remember. Now we come to action potential. Okay, so let's continue this after say 10 minutes, and because I've got my call for Sandhya Aarti, and that is something that I have to go for, and we'll again continue this in the after 10 minutes. I'll again be back.